Brilliant. My name is Praveetha Patalay. I'm an associate professor across both the MRC unit for lifelong health and aging and the Center for Longitudinal Studies at UCL. So essentially the two units between which all these 5 cohort studies sit. And today I'm going to just do a run through of the mental health measures and show you some examples of how we've analyzed the mental health data from the COVID sweeps. Oops. So outline, just to I will run through what we measured and then highlight, because mental health is a special case in this sense, which measures allow within cohort longitudinal continuity and which other measures allow between cohort comparability, and there's some cases in which we have both within and between cohort comparability. And then we'll present some examples from the initial findings that are going to be released tomorrow. So when I say mental health, for the purposes of today's presentation, we have measures of mental ill health, mainly sort of broad psychological distress or symptoms of depression and anxiety. We have measures of well-being, and we have, in this case, measures of loneliness, also because we thought in the context of the social isolation and lockdown, loneliness would be something important to measure that was related to mental health. So in terms of mental ill health, we have some new measures in this particular COVID sweep of the study, which are the PHQ-2 and the GAD-2. So the PHQ-9 and the GAD-7 are usually the versions of these measures that are used more broadly in research. PHQ measures depressive symptoms and GAD anxiety. And there has been efforts to to try and harmonize measures of depression and anxiety across lots of population-based, but also other cohorts and other data sets such as the biobank, using these two particular measures. And in to align ourselves with those efforts, we've included short versions of these measures. So we have PHQ-2 as a short measure of depressive symptoms and GAD-2 as a short measure of anxiety symptoms. But these are included for the first time in the COVID sweep and will be included in follow-up COVID sweeps and other sweeps, but this is the first time they have appeared in our cohorts. And then we have within cohort continuity. So at the NSHG, the 1946 cohort, we've had or included the GHQ-28 item version for most prior sweeps in recent times. So when they were in the 30s and 40s, we had other measures, PSC and PSF, but since the 50s, they've had the GHQ-28. However, the GHQ-28 includes items related to suicidality, and there were worries around this being done as an online measure. So in the COVID sweep, we have a shorter version of the GHQ, which is the GHQ-12. And then in NCDS and BCS, the 1950 and 1970 cohorts, we have the Malaise-9. We've had the Malaise-9 in these two cohorts pretty much all of their adulthood. So this is really nice because in this case, the Malaise-9 gives within cohort continuity, but also for these two particular cohorts allows cross-cohort comparisons, both within time but between cohorts at different ages as well. And then in next steps, we have GHQ-12, and again, next steps has always had GHQ-12, so this provides longitudinal continuity. And in the Millennium cohort study, we include the Kessler 6-item version of psychological distress. And this allows continuity from the previous sweep of MCS, which is when there were 17. However, this data are not available yet, the 817 data. So the COVID sweep is available, but the 817 data are expected to be available in September on UKDS. So that is sort of the longitudinal continuity with case 6 within MCS will start from when they're 17. However, it's also important to flag that we include MCS parents in the COVID sweep and in prior sweeps, and they've had the case 6 at all sweeps since childhood. So within the parents, this represents longitudinal continuity as well. So in terms of well-being and loneliness, we have between and within cohort comparability most of the time. So the life satisfaction question is the single item ONS question, and this has been included in previous sweeps of most cohorts, except MCS, but again will be included in MCS now and going forward. And for loneliness, we have the UCLA 3 in some sweeps of some prior sweeps of the cohorts. And in this case, we've added another item, which is, do you feel lonely? So just if you look at the right-hand bottom corner of the slides, you will see that the UCLA 3 item loneliness measure includes these items on companionship, feeling left out, and feeling isolated. And there was a big review of loneliness measures done 1 or 2 years ago, which sort of criticized this measure for being good and short, but not including an item that explicitly asked about feeling lonely. So now the recommendation is to use the UCLA 3 items and also ask a question on loneliness, which is why we have 4 questions on loneliness. So just to show you some examples of how we've used this data, I will show you some findings from our mental health briefing report, which is going to be published on the website tomorrow. So this is a little bit of a preview of things that will be public tomorrow, but yeah, it's all ready, so nothing will change from today to tomorrow, hopefully. So as I said earlier, mental health is assessed using a common set of common measures across the cohorts in the sweep, and I've just presented some overview of how these are coded. So PHQ-2 and GAD-2 are 2 items with 4 response options. It's coded 0, 1, 2, 3, and so the total score can range from 0 to 6. And there's some sort of established cutoffs that indicate high levels of symptoms. In both cases, it is a score of 3 or above. The UCLA loneliness 3-item scale is the items are coded 1, 2, 3, so you can have a score ranging from 3 to 9. And a score equal or greater to 6 is meant to indicate high levels of loneliness. And the ONS life satisfaction question for life satisfaction, the range is 0 to 10 because they respond on a scale from 0 to 10, where 10 is completely satisfied with life and 0 is not at all satisfied with life. And the ONS has sort of score brackets, and they use 4 and below as indicating low life satisfaction. So for the report, these are the sort of cutoffs we've used when we look at sort of prevalences. So as you can see in this particular graph, we're showing proportions of depressive symptoms, anxiety symptoms, loneliness, and low life satisfaction in the 4 younger cohorts. So this particular report does not include NSHD or the 1946 cohort. And as sort of summarized by Richard earlier, so each of the proportions are based on weighted survey responses, and where necessary, so in MCS and next steps also count for the survey design. And we've used proportions with 95% confidence intervals using the Agresti-Cool method. And we present the findings here separately for males and females. And sort of what you can see very sort of clearly is there's a sort of cohort trend. So for most outcomes, you see this gradient where the NCDs, who is now age 62, have the lowest amount of symptoms, and this increases successively with every cohort. And then the overall pattern between genders that you expect to see as well, which is the females have higher levels of distress than males. So overall, this is a sort of overarching finding that younger cohorts have higher levels of symptoms than previous cohorts, and that for most outcomes, females have poorer outcomes than males. We also look at this by education levels. We just done a binary variable for education. In this particular analysis, we have now dropped MCS because they're 19 and their highest level of education is not reached yet. So this is analysis for next steps age 30, BCS age 70, and NCDS age 62. And again, the overall patterns is what you expect, which is individuals with below degree level qualifications have higher levels of symptoms for most outcomes. And then we see a sort of similar cohort gradient. For most of these outcomes, it seems like the BCS and NCDS are fairly similar, and next steps is sort of has higher levels of symptoms. So then we also present some analysis comparing before to during. So this is longitudinal continuity now. So here we're using malaise 9 for NCDS and BCS and GHQ-12 for next steps. And just to sort of highlight that the prior measures in these cases for the before-during analyses are at age 25 for next steps, age 46 for BCS, and age 50 for NCDS. And as I sort of mentioned earlier, we have age 17 for MCS, but because the MCS data are not yet available, we don't do the before-during analyses for MCS yet, and we're hoping to do them in September. So just to sort of show you how we've done this, we sort of within cohort standardized. So the GHQ-12 was converted to the scale of the malaise inventory using linear stretching, and then it's a standardized score. So if you look at the axis here, you can see that it's sort of 0, and then there's plus 0.4, 0.8, and minus 0.4, minus 0.8. So just to sort of flag that these are standardized scores, so we're looking at change in standardized scores over time, pooled across cohorts and time points. So what we see here is that the before-after, also the before-during estimates are fairly similar in NCDS and BCS in both males and females. And in next steps, we see a difference, but mainly in females. And then we do the same again by education level, and again by education level, the before and during is fairly similar in NCDS and BCS, and then next steps as well by education level is fairly similar, but you can see that it looks like the during is higher in both groups than the before. And we were interested in this because of all the worries around widening inequalities. So by a very crude binary education level variable, we don't see so far, so very early in the lockdown, widening inequalities in mental health based on prior education levels. However, obviously, this future sweeps of the cohorts will tell us whether that is still the case or not after a few months or years. So some other useful resources that I just wanted to flag, which are mainly useful for between cohort comparisons, but also really useful for within cohort comparisons or within cohort analyses in the 1946 cohort, are two pieces of work that are sort of will be public or are public from very recently. One is a project on harmonizing mental health measures, which was led by George Praveetha, and this project is very much focused on within the measures we have or within the data we have to find items that capture common symptoms. So for example, an item of low mood across all measures, and then using these specific items that have comparison. Sample that is representative of the UK population, but not our cohorts, where participants completed all the measures we have of mental health across all the cohorts at any time point, including mental ill health, but also well-being. And then we use test equating methods or scale equating methods to sort of convert these measures into versions of each other to then be able to compare them. The preprint of this work is already up on medRxiv if anybody's interested. And also this data set of this 5,800 individuals, which we call a calibration data set, will also be available via UKDS in near future. Thank you. Any questions?
Thanks, Praveetha. We'll just give people a moment to write in any questions that they might have.
Yeah.
Alex, you have a question now.
Yes, so the question is, what about analysis by race or ethnicity? We have conducted some preliminary analysis by ethnicity, and we're hoping to write a paper on this, which hopefully will be available soon. The thing to flag that is really important is the older cohorts don't have much ethnic variation, so NSHD and NCDS are almost all white, and BCS has a couple percentages of ethnic minorities. So really these analyses on ethnic inequalities have very much focused on the Millennium Cohort Study and Next Steps, because these are the two cohorts with sort of ethnic diversity. Yeah. So the second question is, if I understood well, are you using GHQ-12 for within and cross comparison? Why not use Malays that is available for two core studies? No, so just to sort of clarify, we used in the analyses that was before, during, for each cohort, we use the measure they have. So for BCS and NCDS, that was Malays, and for Next Steps, that's the GHQ-12. So that's why the findings are not. So the prevalences or distributions are not comparable across cohorts, because so the pre-during comparisons can only really be made within cohorts. Also, as you say, NCDS and BCS between as well, but for the most part, when it's Next Steps or any other cohorts involved, it's just really within that we're focusing on, unless we use some of these calibration approaches that I mentioned in the last slide. We have a follow-up question on the ethnicity question on why there's so little diversity in the older populations. It's because these cohorts were recruited at birth, and they were representative of everybody born in 1 week in 1946 and 1958 in Britain. And I guess in 1946 and 1958, Britain wasn't very diverse. So yeah, so these cohorts don't. So as people immigrated to Britain over the decades, they haven't sort of topped up the samples necessarily to be representative of all of the British population. It's representative of everybody born in that week in 1958, when that week happened, if that makes sense. Do you have any measure of alcohol consumption or externalizing problems? Yes, we have alcohol consumption. That is in the sort of health behaviors module. We have done some analysis on that data, and it has been published as a preprint a few days ago. And what we see is a widening of the distribution of alcohol intake, so more people drinking less and more, and there's some inequalities in those as well. Externalizing problems, not. Yeah, we generally in adulthood haven't been measuring externalizing problems very much in most of these cohorts, because externalizing problems tend to be an adolescent childhood thing. So we don't capture externalizing or antisocial behaviors in the COVID sweep. There's a follow-up question on if there's data about profession. Yes, there is data on profession. There's a follow-up question on the cutoff for the GHQ. So the particular analysis I showed you, we used a continuous measure, so we didn't actually use a cutoff. But then usually in other analyses, for example, the preprint on the last slide, where we have used prevalences, we have used the 0 to 36 point scale and then the cutoff, rather than the funny 0011 scoring system. But in this particular analysis so far that I showed you, the pre-during analysis used continuous measures, so we didn't use cutoffs. Any other questions?
There's a question about data by profession. Someone who's interested
I
in
already answered that.
healthcare. Oh, sorry. Yeah.
So yes, we have data on professions,
Yeah.
and they're also coded into occupational classes based on sort of the national standard way of doing SOC codes as well, if somebody's interested in that. Okay, but as Richard said, if anybody has any questions, especially about the mental health data, I'm happy for people to email me or get in touch. Yes, thank you.
Thanks, Praveetha. We'll now move on to the final section.